If I told you that, right now, doctors are literally drawing patients' blood, spinning it down to extract this layer of like liquid gold
Oh,
and
yeah.
then mixing it with synthetic gels before injecting that mixture into, highly sensitive, intimate areas of the body. Well, you might think we were talking about science fiction.
Right. It sounds completely wild.
It really does. But it's not fiction. It's actually a rapidly growing and, frankly, fiercely debated procedure in the regenerative medicine space.
Exactly. And for you listening, the learner who wants to stay on the absolute bleeding edge of medical science without drowning in dense clinical jargon, that is exactly the frontier we are exploring in this deep dive.
Yeah, the mission today is highly specific. We are pulling from clinical protocols, plastic surgery guidelines, and medical journals to answer one central question. Can autologous platelet-rich plasma or platelet-rich fibrin be safely and effectively mixed with hyaluronic acid filler to enhance dermal thickness during a labial puff?
It's a huge question. But before we even get into the physics and the biology of mixing these two very different substances, we should probably establish what a labial puff actually is.
Right. Let's set the baseline for you guys listening.
So a labial puff is a non-surgical volumizing treatment for the labia majora, so the outer lips of the vulva. And patients seek this out for very real functional reasons.
Yeah, and I think that's a crucial point because it's often, misunderstood as this purely cosmetic thing.
Oh, entirely. But over time, due to natural aging, estrogen depletion during menopause, childbirth, or even just like significant weight fluctuations, that specific tissue loses its natural volume and elasticity.
Which means you lose that physical cushioning. Because the labia majora basically act as a protective barrier, right?
Exactly. They're structural protection. So when that volume diminishes, patients frequently experience significant discomfort from chronic friction.
It impacts literally everything. Everyday activities, wearing certain clothing, riding a bike, and it can cause severe pain during intimacy.
Right. So clinical medicine has been desperately looking for ways to restore that structural volume.
And you'd think the answer to, hey, can we mix these two popular treatments to fix it, would be a simple yes or no. But looking at our stack of research today, it involves this mind-bending biological phenomenon called dilutional rheomodulation.
I love that term.
It's a mouthful. And it's also sparked a pretty intense divide among top board-certified plastic surgeons.
It really has. But, to understand why doctors are attempting to mix these things in a single syringe, we kind of have to look at how they behave individually first, like inside the body's tissues, before they ever touch each other.
Okay, let's start with the synthetic side of the equation.
Hmm.
We have hyaluronic acid, or HA.
Right, HA.
Now, hyaluronic acid is a naturally occurring sugar chain in our bodies. It's in our skin, our joints, our eyes. And its main trick is its sheer capacity to hold moisture. I mean, it retains water at up to 1,000 times its own weight.
Yeah, it's an incredible molecule, but the HA used in clinical aesthetics isn't exactly the same as what's just naturally floating around in your body.
No, definitely not.
Because if a doctor injected natural, unmodified HA into your skin, your body would just metabolize it and dissolve it in like a matter of hours.
Right, because our bodies produce hyaluronidase. It's an enzyme that basically acts like a cleanup crew to break down HA.
Exactly. So to make the filler actually last, laboratories have to chemically modify it. They bind the HA molecules together in a process called cross-linking.
Cross-linking, okay.
Yeah, and that transforms it from a fast-dissolving liquid into this thick, durable synthetic gel.
And in clinic protocols, this cross-linked HA is considered the gold standard for what they call hydrodynamic volume replacement.
Precisely. Because when it's injected into the labia majora, that dense gel immediately draws in water. It gives instant cushioning, immediate structural support, and instant relief from that friction pain.
It's a mechanical fix. But there's a catch. Even with the cross-linking, HA is temporary. Your body's hyaluronidase enzyme eventually wins that battle.
It always does. Depending on the product and your metabolism, that volumizing effect typically only lasts about 6 to 12 months before you have to go back for another round of injections.
Okay, so that's the synthetic approach. Now let's talk about the biological regenerators. PRP and PRF, platelet-rich plasma, and platelet-rich fibrin.
Yes. And the most crucial word to grasp here is autologous.
Meaning it comes directly from you. It's not manufactured in some pharmaceutical lab. It is spun down from a sample of your own blood,
Exactly. You go in, they do a small blood draw, pop it in a centrifuge, and use centrifugal force to separate the red blood cells out from the plasma.
leaving you with that liquid gold.
Right. A concentrated fluid that is absolutely packed with platelets.
And platelets aren't just for clotting, right? I mean, our sources describe them as essentially microscopic cargo ships carrying highly concentrated growth factors.
Yeah, things like PDGF platelet-derived growth factor and VEGF, which is vascular endothelial growth factor. These are the actual chemical signals your body uses to heal wounds and build new blood vessels.
And here is the major difference. If you inject PRP into the tissue, you do not get that instant dramatic plumping effect that you get with the HA gel.
No, you don't. Because PRP doesn't volumize mechanically, it's just a fluid. Instead, it triggers a slow biological cascade.
Right.
Those growth factors signal your body's fibroblasts, which are the cellular factories that make the structural framework of your tissues. They tell them to wake up. And they start producing fresh collagen and elastin.
It is actual tissue regeneration. Because PRP is actively rebuilding your own cellular structure from the inside out, the results have incredible longevity. Some of the clinical groups we looked at note that the regenerative effects can last anywhere from 4 to 5 years.
Just fantastic.
But okay, let me challenge the core premise here for a second.
Yeah.
So we have HA, which is this thick synthetic gel that acts like pitching a synthetic tent for instant temporary shelter. And then we have PRP, which is a fluid that's more like planting seeds that eventually grow into a strong, permanent hedge.
I like that analogy.
But why on earth would we want to do both at the exact same time? If HA gives you the volume you need, doesn't mixing it with a liquid plasma just, I don't know, water down the filler and make it weaker?
That is exactly what you would assume. But what's fascinating is that when you combine them, you aren't just diluting a filler, you are fundamentally altering the physical and biological properties of both substances to make them work better together.
Oh, wow.
Yeah. And this is where we get into that massive term you brought up earlier, dilutional rheomodulation.
Right. I was looking at the rheology here, which, for you listening, is just the physics of how matter flows and deforms, and the mechanics seem contradictory.
How so?
Well, HA is a thick, highly cohesive gel. It has a high elastic modulus, meaning it strongly resists deformation. In a highly mobile, delicate area like the labia majora, wouldn't injecting a stiff gel just create unnatural lumps?
It absolutely can. That's a huge issue. A stiff gel in an area subject to constant movement and pressure can lead to uneven distribution. Doctors call it overcorrection. It just feels artificial.
So, using a mechanical analogy, injecting thick HA into delicate tissue is kind of like trying to spread cold butter on thin toast. It's going to tear the bread, or in this case, cause lumps.
Exactly.
But mixing in the liquid PRP is like leaving that butter out in the sun for 5 minutes. It softens the elastic modulus.
That is a perfect way to visualize it. When you mix the low viscosity fluid of the PRP into the thick HA gel, that is the dilutional rheomodulation, it lowers the filler's overall viscosity.
Making it smoother.
Way smoother. It's easier to inject through a fine cannula, and crucially, it glides and spreads much more evenly through those delicate tissue planes.
So you get the instant volume of the HA, but with a much softer, more natural integration because your own plasma has physically softened the synthetic gel.
Exactly. But it's not just a physical change. There is this profound biological synergy happening here, too. We really have to talk about the HA acting as a bioactive scaffold.
Oh, right, because there's a catch-22 with using PRP on its own. If you just inject liquid PRP into tissue, the body's vascular system flushes those growth factors away pretty quickly.
Yeah, they don't stick around in one spot for very long.
So how do you keep them localized long enough to actually force the body to build collagen?
By trapping them. When you mix the PRP with the cross-linked HA, that thick hyaluronic gel acts like a physical net, or like a sponge. It captures the PRP growth factor.
And it keeps them locked at the exact site of injection for a significantly longer period.
Yes. This prolonged, sustained release of growth factors forces those local fibroblasts to stay active much longer. They pump out far more collagen than they would with just a standard liquid PRP injection that washes away.
And the data proving this synergy is wild. There was an in vitro wound healing study we looked at that tested this exact combination on human cells.
Yeah, the results on that were incredible.
Right. When researchers used PRP alone, they saw about 60% wound closure in 24 hours. Which is great. But when they used the HA and PRP combined formulation, they achieved 80% wound closure in that exact same 24-hour window.
It's a massive acceleration in cellular healing, and we see this backed up in clinical applications beyond intimate aesthetics, too. Like, there was a prospective study in Thailand that looked at using this exact combination for neck rejuvenation.
The neck is another area with very thin skin that requires constant movement, right?
Exactly. Another place where thick filler would normally look really lumpy and unnatural, they found that the HA and PRP reinforce each other perfectly. The HA provides the scaffold, the PRP provides the regeneration, resulting in improved skin firmness and elasticity for up to 6 months.
And completely avoiding the lumps. So you are literally hacking your own biology here. You take a manufactured synthetic medical device, and by infusing it with your own concentrated blood plasma, you trick your body into accepting it better and healing itself faster. It is brilliant.
It really is an elegant solution.
So how is this actually translating to the clinic for the labial puff?
Well, in aesthetic clinics, this combination is becoming highly sought after. It's sometimes marketed under trademark names like the vampire wing lift. And clinics explicitly refer to this blend as a super solution for delicate areas.
Because it hits both targets. The HA gives the immediate structural support to instantly stop the pain from friction, while the blood concentrates work over the next few months to physically thicken the dermis and improve the tissue quality.
Right.
But I want to dive into the functional data for a second because the benefits here are definitely not just aesthetic.
No, they aren't. And to measure that functional benefit, researchers use the Female Sexual Function Index, or the FSFI. This is a highly validated scientific questionnaire used globally to measure parameters like sexual satisfaction, arousal, natural lubrication, and pain.
And when researchers actually measured the functional outcomes using this index, the numbers were striking. In one prospective pilot study evaluating these labial treatments, patients treated with just cross-linked HA saw their FSFI scores improve by over 68% at the 3-month mark.
That's huge.
And the patients treated with PRP alone also saw a massive jump, improving by about 45%.
Those are literally life-changing improvements for a minimally invasive in-office procedure. And it perfectly illustrates why clinics are so desperate to combine them. They want to capture that 68% immediate mechanical improvement from the HA, while simultaneously triggering the long-term sensitivity improvements of the PRP.
Now wait, I need to pause here because I want to clear up some acronym soup that keeps appearing in our sources.
Yeah, it gets a bit confusing.
We keep saying PRP, but I also keep seeing PRF, platelet-rich plasma versus platelet-rich fibrin. If a listener goes to a consultation, why might a practitioner choose PRF over PRP to mix with the HA?
That is a really vital distinction. Both are autologous, so both come from your blood, but they are processed differently in the centrifuge. To get PRP, the collection tube must contain an anticoagulant,
Which is a chemical that stops the blood from clotting while it spins.
right. To keep it as a pure liquid, PRF, on the other hand, is spun at a slower speed in a tube with 0 anticoagulants.
So it's 100% natural with absolutely nothing added.
Yes. And because there are no anticoagulants, the PRF actually goes through a natural clotting cascade. It forms a fibrin matrix all on its own.
What does a fibrin matrix actually look or feel like?
Think of it like a natural, spongy, three-dimensional web. It's a biological gel made entirely of your own proteins. And because it's a web, it naturally traps its own growth factors, releasing them even slower than PRP.
Oh, wow.
Yeah, but the science gets even more advanced. Some clinics are now taking that PRF, extracting the albumin protein from it, and heating it in a specialized device.
Wait, let me make sure I have this right. They're taking a patient's plasma, extracting a protein, and literally cooking it.
Essentially, yes. By heating the albumin protein to a specific temperature, you denature it.
That is wild. It's like boiling an egg. You're taking the clear liquid egg white, adding heat, and physically changing it into a solid rubbery mass.
Yeah.
But they are doing it with a patient's own blood plasma to create a dense gel.
That is exactly the mechanism. They create this thick autologous gel from the heated albumin, and then they mix the unheated live growth factors back into it.
So a doctor might choose PRF because it can act as a dermal filler all by itself. It provides natural volume alongside the HA. Or, for some patients, you can replace the synthetic HA entirely for a fully natural procedure.
Exactly.
Okay, a fully natural filler made from your own heated blood that restores volume, stops friction pain, and boosts FSFI scores. It sounds like the ultimate silver bullet. But
Yeah.
this is where we have to look at the other side of the medical crossroads.
Yeah.
Because medical science is rarely unanimous.
And treatments are never without risk. While many med spas and clinics are praising this HA-PRP mix, there is a very strong, very vocal dissenting view coming from highly respected board-certified plastic surgeons.
Right. We have to talk about the pushback. Our stack includes the clinical perspective of Dr. Karen Leong, who is a member surgeon of the American Society of Plastic Surgeons, or ASPS, and her stance, backed by ASPS data, is starkly different.
Very different.
She explicitly states that she does not recommend using any hyaluronic acid fillers for the labia puff.
Period. Even if it is mixed with PRP or PRF, and it is crucial we understand the biology of why she takes this position.
Right.
The vulvar region is an incredibly complex, highly specialized anatomical area. It has a unique and dense vascular network. It is subject to constant friction, pressure from sitting, and significant hormonal fluctuations.
And according to Dr. Leong in the ASPS, introducing a synthetic cross-linked gel like HA into that specific high-pressure environment carries documented risks, the most significant being the formation of granulomas.
Granulomas are a severe complication. We really need to explain what that actually means on a cellular level.
Okay.
Essentially, your immune system's macrophages, the white blood cells that patrol your body looking for foreign invaders, they recognize the synthetic HA gel as something that doesn't belong.
But the gel is thick and it's cross-linked. The white blood cells can't easily break it down and carry it away.
Exactly. So your immune system does the next best thing to protect you. It builds a wall of dense, inflammatory scar tissue entirely around the filler to isolate it from the rest of your body.
It just quarantines it.
Yes. And that immune quarantine manifests physically as a hard, sometimes painful nodule or lump under the skin.
Oh, wow.
Yeah. And in an area as sensitive and densely innervated as the labia majora, a hard inflammatory nodule is the absolute last thing a patient wants.
That completely defeats the functional purpose of the procedure. You go in to reduce friction discomfort, and you walk out with a hard, painful lump. So, for specialized surgeons who refuse to use HA below the belt, what is their alternative? How are they achieving the labial puff without the synthetic gel?
Dr. Leong and other board-certified plastic surgeons generally advocate for two distinct alternatives. The first is using specific biostimulatory fillers, like calcium hydroxylapatite.
Which is very different from HA. Instead of acting like a water sponge, calcium hydroxylapatite is actually made from microscopic, bone-like minerals suspended in a gel. It actively irritates the tissue just enough to force the body to build permanent collagen around the microspheres.
Exactly. But the second and often preferred surgical route is autologous fat transfer.
Using the patient's own fat.
Yes. The surgeon performs a minor, targeted liposuction, usually harvesting fat from the abdomen or the inner thighs. They purify that fat in a centrifuge and then carefully inject it into the labia majora.
So the living fat cells act as the instant volumizer instead of the synthetic HA gel.
Right. And the biological advantage there is massive. Because it's your own living tissue, it is recognized as self.
Ah, so there is zero risk of a foreign body reaction.
Yeah.
Your immune system has no reason to attack it, so it won't form a granuloma.
Exactly. And to bridge the gap we've been discussing today, many surgeons will actually mix that harvested fat with PRF.
Really?
Yeah, so you are still utilizing the regenerative growth factors. You are still creating a bioactive scaffold to boost blood supply to the newly transferred fat cells, but the structural volume is coming entirely from your own living tissue.
It integrates naturally and permanently, but there is a significant trade-off.
Yeah.
Right. Fat transfer is a surgical procedure. It requires liposuction. It requires local anesthesia, and it involves actual downtime for recovery. You cannot just walk out of the clinic and go straight back to work like you can with a simple HA injection.
No, you can't. And that perfectly encapsulates the current tension in this field.
It really does. On one hand, you have aesthetic clinics praising the HA-PRP super solution for offering instant relief, lowering the physical viscosity of the gel, and delivering high patient satisfaction with zero downtime.
Right.
And on the exact opposite side, you have specialized plastic surgeons warning about the long-term immune risks of foreign body reactions, advocating for surgical fat grafting to guarantee natural integration.
And look, we aren't here to declare a winner between the two philosophies. Both approaches have valid scientific foundations, and both carry distinctly different risk profiles. What this debate truly highlights is just how rapidly the field of regenerative, intimate aesthetics is evolving.
It really requires a deeply informed conversation between a patient and their doctor about what risks they're willing to take.
Yeah.
You have to weigh the risk of a synthetic immune nodule against the surgical downtime of a fat harvest.
Exactly. Knowledge is most valuable when it is understood mechanically and applied carefully. Understanding the why, knowing why a granuloma forms, or how HA physically traps growth factors, or how heating albumin changes its state, that empowers the patient to make a choice based on science, not just marketing.
Absolutely. So to bring this deep dive full circle for you listening, the answer to our initial question is yes, autologous PRP and PRF are actively and successfully being mixed with HA filler for labial puffs.
They definitely are.
This dilutional remodulation lowers the stiffness of the gel, allowing it to spread smoothly, while acting as a bioactive net for your own regenerative growth factors.
Okay.
But because it relies on a synthetic gel, it is never entirely without the risk of an inflammatory response.
It is the ultimate attempt to marry structural engineering with organic biology.
It is. Which leaves me with a much broader concept to chew on. We just spent all this time discussing how we can use a patient's own blood plasma to alter the physical properties of a synthetic dermal filler. We are basically tricking the body's immune system into accepting a foreign gel by cloaking it in autologous growth factors.
Basically hacking the immune response.
Exactly. If we can use our own biology to successfully hack how our body responds to synthetic gels in aesthetic medicine, what is next?
Oh, the broader medical applications could be limitless.
Right. Could we eventually coat artificial titanium joint replacements or synthetic heart pacemakers or other vital medical implants in our own concentrated heated plasma gels?
Wow.
Could we completely eliminate the body's immune rejection response to life-saving artificial implants by using the exact same dilutional remodulation principles they're using in med spas right now?
It is a staggering thought. Taking the highly debated aesthetic science of today and making it the critical, life-saving surgical science of tomorrow.
It really makes you realize that the future of medicine isn't about choosing between the synthetic solution or the organic one. The future is realizing the synthetic structure will never truly hold unless our own biology is convinced to embrace it. Thank you for joining us on this deep dive. Keep questioning the consensus, keep learning about the mechanisms driving your choices, and always keep looking beneath the surface.